Can you guys hear me okay? All right, so like Dr. Regelman said, I want to talk to you about the role of vitamin D in lung disease and really just kind of describe some of the more recent literature that's out there looking at the role of vitamin D deficiency. And then at the end, I'll talk about the research I did specifically in the cystic fibrosis population. My objectives are to describe the role of vitamin D deficiency in lung disease, and then discuss the prevalence and cause of vitamin D deficiency in cystic fibrosis, and then define the role of vitamin D deficiency in pulmonary outcomes in cystic fibrosis. So first, just a general overview about vitamin D. Vitamin D metabolism, we get most of our vitamin D from sunlight. There's few foods in our diet that are high in vitamin D, mainly just fatty fish like salmon, and then supplemented cereals or grains. But it's converted to cholecalciferol or vitamin D3 in the liver, and that's once in the liver, then it's converted to 25-hydroxyvitamin D. So when I talk about vitamin D kind of throughout this talk, I'm referring to that form. That's the storage form. And when we measure for vitamin D deficiency, that's the form we look at, because the half-life is about 2 to 3 weeks versus the active form of vitamin D, which happens in the kidney by another hydroxylation step. That half-life is only a couple hours. And we all know about vitamin D with the kidney, and that it, low calcium, high PTH, all stimulate the active form to be produced, and then increases intestinal calcium absorption and helps with bone formation. But more recently, studies have shown that vitamin D isn't just associated with bone health. In fact, they found vitamin D receptors to be throughout most cells in our body. And so multiple disorders have been associated with vitamin D deficiency. So diabetes, an increased incidence of Crohn's disease, cancers like colon cancer have been associated with vitamin D deficiency, and heart disease. And then for me, my main interest obviously is its association with lung disease, and there's studies showing an increased incidence of wheezing and viral illnesses with vitamin D deficiency. And we'll talk about these studies more specifically. But the definition of vitamin D deficiency, there's not a great consensus as far as, when you talk about rickets in kids, you talk about a vitamin D level of 10 or below. But as far as these extraskeletal effects, it's still not quite clear what is deficient and what's a sufficient level for these. But mainly what we look at now is less than 20 micrograms per liter is considered deficient, and a level of 30 or above is considered sufficient. And these come from a couple of review studies, one that looked at parathyroid hormone and found that at its lowest level was when vitamin D was between 30 and 40. And then a review study looking at vitamin D levels in relationship to bone health and colon cancer and dental caries found that at levels of 30 to 40, these diseases were decreased. And then lastly, there was a study looking at women who were given vitamin D supplementation, and their intestinal calcium transport increased up to 60% when their levels went from 20 to 32. So because of that, we've looked more at this level of 30 for the extraskeletal effects. And the Cystic Fibrosis Foundation recently came out with their new guidelines for vitamin D in cystic fibrosis, and their recommendations also are to keep the levels above 30. So the prevalence of vitamin D deficiency, it's pretty common. It's actually estimated that about 50% of people worldwide are vitamin D deficient. It's hard to get a great number because it depends on the population studied, the season of the study, and the definition that's used. But I pulled kind of a couple numbers just looking at different populations of children. So one study found about half of Hispanic and Black adolescents were vitamin D deficient. Looking at healthy medical students in Boston, about 30% were deficient. And then this study came from NHANES data where they looked at 1 to 11-year-olds and their vitamin D levels. And you'll notice the numbers are a little different there, but this 75 millimoles per liter is the same as about 30 micrograms per liter that I mentioned as being sufficient. And so in the preschool kids, about 50% were vitamin D deficient or insufficient, and that increased to almost 75% in the older kids. And then you can see across the different ethnicities, there's a wide range of different prevalences of deficiency. So as far as vitamin D in lung disease, there's been multiple studies showing that it may be associated with a variety of diseases. So it's been associated with vitamin D deficiency has been associated with decreased lung function, decreased lung growth, more incidence of asthma or more severe asthma exacerbations, more tuberculosis, and decreased immunity to different pulmonary infections. And I'm just going to go through some of these studies. So one of the biggest ones looking at vitamin D and lung function was the NHANES 3 study. And this was a cross-sectional study of over 14,000 healthy adults, and they looked at their vitamin D levels and their FEV1 and FVC as markers of their lung function. And their vitamin D levels were divided into 5 different groups, which was less than 16, which is deficient, and then the highest group was greater than 34, which is sufficient. And they found that the difference between each group of vitamin D, the lower groups had significantly lower lung function. And the difference in the FEV1 between the most deficient group and the sufficient group was 126 milliliters and 172 milliliters in their FVC. And this was significantly different and held true even after they adjusted for age, smoking status, gender, height, and BMI. And what I thought was interesting, too, is, we know smoking severely affects lungs and lung function. And when they looked at the difference in FEV1 of those who had never been smokers versus those who were previous smokers, that difference was lower than the difference between those who were vitamin D deficient and those who were vitamin sufficient. So it really stands out that vitamin D may be playing a role in lung function. And then they've looked at vitamin D as far as lung development in a couple animal studies. One was in rats, which looked at mothers fed vitamin D deficient diets, and then the rats born to those mothers their lungs were measured, and they had lower lung weights, lower lung volumes, and decreased compliance. And then a second study was very similar in mice, but they also looked at somatic growth, thinking that the decreased lung volumes could be because the rats who were vitamin D deficient were smaller. But they actually had no difference in their somatic growth, but still had decreased lung volumes. And histologically, they found that they had decreased alveolarization, which is important for our population because early on in life, we're still developing our alveoli, and our lungs continue to grow and develop through, age 8 or so. And so monitoring vitamin D levels early on could be important. And then the same with asthma. There's a lot of studies out there now looking at vitamin D deficiency and the risk of developing asthma or the severity of asthma. And so a couple maternal studies looked at mom's vitamin D intake during pregnancy and then followed the kids through the first 3 years of life and recorded how many times they were seen for wheezing. And unfortunately, they didn't check anyone's vitamin D levels, just went by diet history, but they did find that the lower maternal intake of vitamin D was associated with a significantly greater incidence of wheezing at age 3. And then the same group did a similar study but looked at cord blood vitamin D of the babies and then followed mom's diet prenatally and through the first 5 years of life and followed the children's diet. And they looked both at wheezing and then doctor-diagnosed asthma. And they found that lower cord blood vitamin D was associated with more increased incidence of wheezing through the first 5 years of life, but not with doctor-diagnosed asthma. And then there's a study in Puerto Rican children looking at the risk of asthma exacerbations and vitamin D deficiency. So, we think of vitamin D deficiency, especially here or Wisconsin where we have these long winters. and no sunlight. But even in Puerto Rico, they did, I think, have about 60% of kids in this study were actually vitamin D deficient. But they found that those who were vitamin D deficient or insufficient, which was measured by a vitamin D level less than 30, as we talked about earlier, had 2.5 higher odds of having had an asthma exacerbation in the prior year, which was either they were started on oral steroids or they were hospitalized for asthma. And then they also adjusted for their other confounding factors, like if they had a history of atopy as well, or in that population if they had a history of African ancestry, in case the darker skin color was associated with the higher incidence of vitamin D insufficiency. So it's not really clear why we see a higher incidence of asthma or more severe asthma with vitamin D deficiency, but some of the proposed mechanisms are one that you have, in asthma you have a lot of airway hyperplasia and airway remodeling, and matrix metalloproteinases, or MMP9, are responsible for extracellular matrix breakdown and lead to a lot of this inflammation. And the vitamin D has been shown to decrease the amount of these MMP9s and decrease smooth muscle cell proliferation. Also, it's thought that the T cell response is altered with vitamin D and move towards a more less inflammatory response if you have sufficient levels of vitamin D. And then, so when you give the glucocorticoids or oral steroids in asthma, it's supposed to increase your IL-10 and decrease inflammation. But there's a subset of patients who don't respond to this, and their IL-10 doesn't increase. And they found that if you give them vitamin D supplements as well as the glucocorticosteroids, then their IL-10 does increase, and they do become more steroid responsive. And then one of probably the earliest known non-skeletal effects of vitamin D was in its history with tuberculosis. So it was before they knew what vitamin D was, it was initially the sunshine cure, because they knew that the only effective cure for tuberculosis was to be in warmer, sunnier climates. And then in the 1800s, there was a report by one physician that cod liver oil was the only cure for TB, and obviously cod liver oil is high in vitamin D. So since that time, now in the last 20 years or so, there have been lots of studies looking at the prevalence of tuberculosis in multiple ethnic groups in relation to vitamin D deficiency, and across all different groups they've seen higher incidence of tuberculosis with vitamin D deficiency. So the thought is, well, should vitamin D be added to typical TB therapy? And there have been some studies that have had conflicting results, but one study gave high doses of vitamin D plus conventional TB therapy and found that in children, those who got vitamin D had less febrile illness episodes. They had a decrease in their lymph node size. And then in adults who were producing sputum, their sputums converted to negative sooner than those who weren't supplemented with vitamin D. But, again, there's other studies that haven't shown the same effect, so it hasn't become the standard of care to add vitamin D. And then vitamin D and viral illnesses are kind of where a lot of the studies are right now in the association of increased viral illnesses. So again, one of the bigger studies with that comes from the NHANES 3 data, and this one looked at almost 20,000 kids and adults that were 12 years of age or older, and they asked, in the past few days, have you had a cough, cold, or other acute illness? And then at that same time as the survey, they did spirometry to look at lung function and drew vitamin D labs. And then they adjusted for other things like season, BMI, sex, smoking history, asthma history, COPD in the adults. And they found that about half of the patients were vitamin D deficient or insufficient, and 19% had had a recent upper respiratory tract infection. And And when you look at the actual difference between the vitamin D of the group that didn't have a respiratory tract infection versus the group that did, it was 29 versus 28, which doesn't seem like a big difference, but it was statistically significant. But I think the more telling comparison was when they looked at everyone who was vitamin D sufficient and then looked at the vitamin D deficient group. The deficient group had 55% higher odds of developing an upper respiratory tract infection, and the insufficient group had almost 30% higher odds of developing an upper respiratory tract infection. And then, again, even when they adjusted for season of the year, you can see that this is the vitamin D deficient in the vitamin D sufficient groups, and there is a higher incidence of upper respiratory tract infection in all seasons in the vitamin D deficient group. And, we look at influenza and RSV are two big hits in the wintertime, and our vitamin D levels tend to be lower in the wintertime. So the question was there any association with these two viruses and vitamin D deficiency? So this was a study out of Japan looking at influenza and vitamin D deficiency, and they compared the incidence of influenza in kids that they supplemented with vitamin D and then kids that just received placebo. So they took a vitamin D supplement through the influenza season from December through March, and then if they had any symptoms consistent with a viral illness, they were seen by their primary, and a nasal swab was done to diagnose influenza. So again, unfortunately, they didn't measure vitamin D levels. They just went with supplemented or not supplemented. But they did find that influenza occurred in only about 11% of the vitamin D supplemented group, but it was seen in 19% of the non-supplemented group, which was a significant difference. And then when they looked at the second month of the study was when most of the influenza cases occurred. There was even a greater difference in that the vitamin D group had only had about 5% of cases of influenza. In the placebo group, 13% of the patients had developed influenza. And then again with RSV, this was a study that was recently published in Pediatrics of 150 term neonates, and they drew cord blood and then followed these babies to see who would develop RSV and if it was related to their vitamin D levels. So 12% of the babies developed RSV. As a group, the mean vitamin D level was actually sufficient. It was 33, but it was lower in those with RSV than those without. So again, these are numbers on the different scale, but in the group that did develop RSV, their vitamin D levels were about 25 micrograms per liter, compared to the ones that did not develop vitamin D, theirs were about 35. And then when you looked at the deficient group, insufficient group, and sufficient vitamin D group, the deficient group had 3 times the relative risk of developing RSV than the sufficient group. There's all these studies showing that there's an increased incidence of vitamin D or of viral illnesses with vitamin D deficiency, but there's also one study that suggests that you may have more severe illness as well. So this was a study out of Canada, and they looked at kids under the age of 5 who were hospitalized with an acute lower respiratory tract infection and compared them to those who are hospitalized for non-respiratory symptoms. So of the respiratory group, half of them were diagnosed with bronchiolitis, half of them were diagnosed with pneumonia, and then the 92 non-respiratory patients were hospitalized with things like gastroenteritis or fever of unknown origin. A couple were hospitalized with trauma. And what they found was that between the study group and the control group, there was no significant difference in their vitamin D levels. And in fact, they were actually, on average, sufficient vitamin D levels. But when they then looked at those with respiratory illnesses that were admitted to the pediatric ICU, their vitamin D levels were 20 compared to respiratory tract illnesses that were admitted to the floor. Their vitamin D levels were 35, and that was significantly different. And then again, the controls were significantly different from those admitted to the ICU. And then they separated them out and looked at the prevalence in the different groups of who was vitamin D deficient and who was insufficient. So this is our deficient group, and this is our insufficient group. And when they looked at the control group versus all of the lower respiratory tract illnesses combined, there was really no difference between the prevalence of deficiency and insufficiency. But when they separated it out as pneumonia, versus bronchiolitis, the pneumonia group had significantly more kids who were vitamin D deficient than the control group. And then again, when they looked at ward admissions versus PICU admissions, the PICU had significantly more kids who were vitamin D deficient and insufficient. So the mechanism behind, how is it helping to fight against infection, again, isn't completely clear yet as well, but there is suggestion that this antimicrobial cathelicidin that has activity against, gram-positives, gram-negatives, viral infections, fungal infections, that may be involved in. One study looked at bronchial epithelial cells, both from normal subjects and then subjects with cystic fibrosis, and treated them with the active form of vitamin D, and found that there's increased expression of cathelicidin in both cell lines within 12 hours, and then that the growth of Pseudomonas was decreased by 50%. So what I think is happening, so some of lung cells can just activate vitamin D on their own. Others need, like the macrophage, needs to be stimulated itself before it can activate vitamin D. So once the organism, the bacteria or virus, attaches to the toll-like receptor, then that stimulates this vitamin D receptor. And you get more expression of the vitamin D receptor, and you get more expression of the hydroxylase enzyme, which hydroxylizes the storage form of vitamin D to its active form of 125-OHD. And then that complexes with the vitamin D receptor and this retinoic acid receptor, and in the nucleus of the cell increases the production of cathelicidin, and then cathelicidin has these effects on all these different bacteria and viruses, and then they think that also plays a role in activating the T lymphocytes and B lymphocytes. So my area of interest is cystic fibrosis. So why is vitamin D important in cystic fibrosis? We talked about a prevalence of about 50% of vitamin D deficiency in the general population. In cystic fibrosis, again, it depends on the age and definition used, but we see up to 90% of that population is vitamin D deficient, probably mainly because of malabsorption, because most are pancreatic insufficient, but some other causes as well. And really, this has just been more noticed in the last several years as the life expectancy has increased later into adulthood, and now we're seeing more effects of bone disease with vitamin D deficiency. And so lung disease hasn't been looked at as much, but lung disease is the major cause of morbidity and mortality in cystic fibrosis, and pulmonary exacerbations, which are from viral infections or Pseudomonas, usually play a major role. And so as we went through all these other studies, it seems that vitamin D may affect some of these things. So the causes of vitamin D deficiency in cystic fibrosis, again, like I said, more than 90% of patients are pancreatic insufficient, so they're not able to absorb vitamin D. But also there are studies showing that they have decreased 25-hydroxylation of vitamin D. It's thought they have reduced sunlight exposure, one, because either they're on antibiotics that make them too sun sensitive and they don't go outside, or they're just too sick to be outside. They have less vitamin D binding protein to bring vitamin D to the liver. They have reduced body fat stores, and it's thought that there's other intrinsic problems with the CFTR leading to vitamin D deficiency, because despite being pancreatic insufficient, they're given enzymes to help absorb their vitamins, and we don't see the same problems with other fat-soluble vitamins as we do with vitamin D. And this study by Lark and colleagues looked at the actual absorption of vitamin D in CF compared to controls. And so what they did was everyone got a dose of vitamin D2, and then those with cystic fibrosis got their enzymes at the same time, so that in theory they were absorbing the vitamin D. And what they saw in this first graph is looking at what their vitamin D2 level did over the next 36 hours, and you can see the top line is the control group, and their vitamin D2 level went up significantly higher than the CF group. And then when they looked at the conversion of vitamin D2 to 25-hydroxyvitamin D, the difference from baseline to 36 hours for the control group was significantly higher, whereas the difference from baseline at 36 hours, there was no change in the CF group in their conversion. So it's thought that in CF, they probably absorb about half of what the control subjects were absorbing, and then that's not converted as much as what a control subject level was. So studies looking at vitamin D in lung function in CF are, there aren't a lot. Actually, since I've started doing this research, there's been a lot more, but most of the studies initially were in adults, and usually they're looking at bone mineral density and look at vitamin D as, or as lung function as a predictor of vitamin D deficiency. But a couple studies, one that looked at vitamin D level and then looked at their PFT levels during that same year, and they used the patient's lowest PFT value in a year and their highest PFT value in a year, and found that their lowest PFT value was significantly lower if their vitamin D level was lower. And in that group, 75% of the patients were vitamin D insufficient or deficient. And then another group found similar findings, that those who had the lowest vitamin D levels, so vitamin D levels of less than 10 micrograms per liter, had significantly worse lung function than those with vitamin D levels that were at 20 or above. And then in kids, there aren't as many studies. Most of the studies are looking at the prevalence of vitamin D deficiency. Ones that do look at lung function have had conflicting results, and they mostly look at linear relations. You know, from that first study I talked to you about, where they broke the vitamin D groups into 5 different levels, suggests that maybe there's more of a threshold level where you see an effect on lung function. And then everyone tends to use a different definition of deficiency, so it's really hard to kind of make anything out of the studies that are available in children. So when I was looking at doing my research here during fellowship, that was kind of the gaps that I had identified, was that we didn't really know if it was a linear response or a threshold effect. And, you know, as we correct vitamin D levels in our patients, we didn't know if there was a cumulative effect on their lung function over time. And no one had really looked at other markers of lung function, like pulmonary exacerbations or first growth of Pseudomonas. And then, again, we didn't know what a definition of sufficient is for its pulmonary effects. And children offer the ideal time to intervene because, like we talked about, they're growing new alveoli and their lungs are continuing to grow. So the aim of the study was to define the relationship between vitamin D, lung function, and pulmonary exacerbations in children with CF, and determine if there was a threshold effect of 25-OH vitamin D that optimized its pulmonary effects. And so the hypothesis was that children with 25-OHD levels less than 20 and less than 30 would have pulmonary function, lower pulmonary function, and more frequent pulmonary exacerbations than those with 25-OHD levels that were 30 and above. And so the way this was done is, we're fortunate to have a large CF Center database here that we used, and we identified 130 children between 6 and 18 from the years of 2000 and 2012 who had vitamin D measurements and lung function measurements. And we trended them by categories similar to the definitions that I mentioned before. So deficient was less than 20 and sufficient was greater than 30. And then each patient's study record began with the first measurement we had in our database of their vitamin D level, and then we followed them yearly till they were 18 or the end of the study. Or if anyone developed liver dysfunction during that time, then we didn't continue to follow their numbers because that would affect their vitamin D levels possibly. And so we looked both at longitudinal measures and cross-sectional measures. So for longitudinal models, we followed the individual's changing vitamin D groups over time. So if they were sufficient at one point, they were categorized in the sufficient group, and then the next year if they were deficient, then they were categorized in the deficient group. And we compared them by the number of pulmonary exacerbations, which our marker of that was if they were hospitalized, and then by incidence of first Pseudomonas infection. And then we looked at their percent predicted lung function. And then cross-sectionally, we compared by vitamin D group their lung function and other markers of nutrition like vitamin A and E and BMI. And we did this analysis just in 3 age groups, in 8, 12, and 16, because both vitamin D and lung function tend to get worse with age. So we took age out of the picture and just looked at 3 specific ages. So we had 130 children with over 2,000 pulmonary function tests and 450 measurements of 25 OHD, and we found that the proportion of children with vitamin D deficiency or insufficiency increased through adolescence. So in the 6 to 10-year-olds, less than 35% were vitamin D deficient or insufficient, but in our adolescents, 40% were deficient or insufficient. And then our biggest finding was when we looked at the hospitalization rate, the vitamin D deficient group had 3 times the rate of hospitalizations than the vitamin D sufficient group. So on average, they were hospitalized at least once a year with a pulmonary exacerbation. And then looking at Pseudomonas was a little harder because by age 6, 2/3 of our study population had already grown Pseudomonas, so we only had 48 kids who we could follow to see when they first grew Pseudomonas, so we didn't find a significant difference among the vitamin D groups with that. And then our cross-sectional comparison, there was no significant difference across the ages between vitamin D groups and BMI or other markers of nutrition like vitamin A and vitamin D. And in fact, their BMI and other than vitamin D levels were all within normal on average, other than at age 8, the BMI was on the lower side. And then for lung function, we found that the vitamin D sufficient group at 8, 12, and 16 years, by this brighter blue, had higher lung function than the deficient group, but it was not a significant difference, though it was a difference of between 3 and 13%, depending on age. And same with FVC, as it wasn't a significant difference in lung function, but there was a difference of up to 13%. And then when we looked at vitamin D as the predictor rather than their vitamin D group as the predictor, and sorry, this is hard to see, but this is their percent predicted FEV1 at ages 8, 12, and 16. And this is their vitamin D levels. And what we found was that for every 10 microgram per liter increase in vitamin D, their FEV1 increased by 4 to 5%. And that was statistically significant only in our 16-year-olds who their FEV1 actually increased by 5.5%. But again, though not statistically significant, we talk about FEV1 dropping on average of 1 to 3% per year in CF, and so if we're seeing a change of 4 to 5% by just increasing vitamin D, that's clinically significant. And then because our We were surprised that we didn't see any cross-sectional effect really with lung function when vitamin D as the 3-group split. We looked at it as just 2 groups as being sufficient or not sufficient. And no differences, again, at ages 8 and 12 in pulmonary outcomes or BMI percentile, but there was a significant difference in the 16-year-olds in that they had significantly higher FEV1 and FVC if they were vitamin D sufficient. And then this is looking at, so these light gray lines that are going all over the place, that is each individual study participant's lung function over the study period. So you can see lung function is kind of a hard measure because everyone is all over the place throughout each year. But then we looked at their percent predicted FEV1 according to their vitamin D group. So this dark black line is the sufficient group. This light gray line is the insufficient group, and the dashed line is the deficient group. And the average rate of decline in lung function varied by age. But for each pulmonary outcome, there are significant differences in the shapes of the mean profiles. And I just have FEV1 up here. But it tended to be that the vitamin D deficient adolescents, again, had generally lower FEV1, FVC, and FEV1 FVC ratio over time. So again, based on our literature review, we expected to see a stronger relationship between vitamin D and lung function, but we're surprised to see that there was really a significant difference between the amount of pulmonary exacerbations depending on vitamin D or vitamin D sufficient or deficient, which is important in CF because the pulmonary exacerbations negatively impact lung function. So on average, FEV1 decreases by about 4% with each exacerbation. And there's one study looking at recovery, and about a quarter of children who have a pulmonary exacerbation fail to recover to baseline. And we, really focus on the FEV1 and trying to keep it as high as possible because as I mentioned, it falls 1 to 3% a year on average, and as you get to a level around 30, that's when we talk about lung transplant. And so luckily we're at a time right now where, at least in my training, I've rarely seen a child who needs lung transplant, but we want to keep our kids as healthy as possible going into the adult clinics and their lung function as high as possible. And then it's also seen that the 8-year mortality risk is 4 times higher in children who've had a recent pulmonary exacerbation, and it negatively impacts quality of life. So one study looking at health-related quality of life found that between CF patients and healthy controls, their psychosocial scores were no different from each other, but after a pulmonary exacerbation, those with CF scores fell significantly below baseline. So how does vitamin D prevent pulmonary exacerbations in CF? Again, about 60% of pulmonary exacerbations are likely viral in nature. And like we talked about at the beginning of this talk, it looks like vitamin D deficiency may lead to more viral infections. And then this is, there's studies out of Emory right now that are ongoing, but this was one of their pilot studies looking at supplementing with vitamin D at the time of a pulmonary exacerbation. So this was in adult CF patients, and they were given a high dose of cholecalciferol at the time of an admission for a pulmonary exacerbation, and then followed for the next 6 months. And their vitamin D levels stayed above 30 during that 6 months, and they also were found to have fewer pulmonary exacerbations than those that received placebo. And they're doing studies right now looking at markers of inflammation with these same patients and seeing that the markers of inflammation were higher in those that didn't receive the vitamin D. And then as far as the clinical impact, when you compare this study with other studies, it's the first one describing the longitudinal relationships between vitamin D and lung function in children with CF. The other cross-sectional studies that I kind of mentioned really didn't show an association except for one study, but they didn't adjust for age. They had a younger mean age, and where we saw the differences was in the adolescents. And then one study, 80% of their population was vitamin D deficient, so I don't know that they had the numbers to actually really evaluate those who were sufficient. And then, again, we didn't find a significant difference in FEV1 or FVC, but it was 3 to 13% higher in the sufficient group compared to the deficient group. That, although not statistically significant, is clinically significant in that we're trying to find anything that can help prevent this decline in FEV1 that we see in these kids. And so, like I mentioned, it's a decline of 1 to 3% a year. And so if we can just stall that out by improving their vitamin D status, that would be helpful. We did have limitations in that it was a retrospective design, so we can't make any conclusions about a causal connection between vitamin D and lung function. And then again, our measure of pulmonary exacerbation in our database, our only measure is whether or not they had inpatient PFTs as a marker of hospitalization. But we do treat kids for exacerbations as outpatients, and then we don't have a standard definition of an exacerbation, so depending on provider, someone may be admitted and counted towards an exacerbation in the study, but someone who may be just as sick may be doing things outpatient, and so we may have missed some numbers. And we couldn't detect for Pseudomonas because most kids do grow that before the age of 6, but our study was looking at lung function, and we can't really test lung function until they're about 5 or 6, so that was a harder measure to look at. But in conclusion, we found that pulmonary exacerbations are 3 times higher in those who are vitamin D deficient than sufficient, which helps support the CFF's recommendations to keep vitamin D levels at 30 or above. Adolescents with CF and higher vitamin D levels have higher FEV1, and there's a trend of increasing FEV1 across all age groups with vitamin D sufficiency. And I think that the study itself provides evidence to support further clinical trials looking at using vitamin D as adjunct therapy in CF. And then this I just put up because no one knows where Marshfield is. So this is where I have traveled to. So Marshfield's in the middle of the state of Wisconsin, and the clinic is really the only major hospital for all of north central Wisconsin. Otherwise, you just have Madison and Milwaukee taking care of the southeastern part of the state. So here, this is the hospital clinic, and then they have a large research facility as well that is all in rural Wisconsin in the middle of a bunch of farm fields, but it's a big institution. So, and then just acknowledgments, as Dr. Regelman said, the CFF funded this research during my fellowship, and then my research committee, which was Dr. Paul Green, Will Thomas, Dr. Moran, Dr. Laguna, and Dr. Regelman. That's all.
We can take some questions.
Sure.
In the vitamin D sufficient group, was there a relation between the level of vitamin D? I mean, if, say, it was 30 versus 40, was there a difference in exacerbations that was seen?
I don't know for exacerbations because we only looked at for that marker, we only looked at 30 or 20 to 30 and less than 20. But as far as just in general at their lung function, it seemed that for every 10 microgram increase in vitamin D, their lung function increased by about 4 to 5%. So we didn't find, I thought we may find, a threshold of, at 30 you see improvement, and then once you get to 40, it kind of tapers off, but it seemed to be more linear than that.
And are there drawbacks to, or is there a relation between hypervitaminosis?
You worry about hypervitaminosis. It's really hard to get in cystic fibrosis. It doesn't happen. Probably less than half of patients that we treat with high dose of vitamin D actually even become sufficient just because of the underlying defects.
Based on what we know about CF and vitamin D, are you taught under clinical practice on that then? So, I mean, are they getting twice as much vitamin D as your average patient based on their absorption and other things? Or?
Yeah, well, with the CF's new recommendations, they have new guidelines for where to start their routine supplements at, and then we monitor their vitamin D levels every year, and if they're low, their supplement is increased, and then their levels are followed every 3 months until they get to a sufficient level. So you have kind of a continuous scale that you increase it on. But,
And then the high dose vitamin D, is that accepted? Exacerbation? That sounds like a high dose.
It is, because even with those levels in this population, like I said in CF, it's really hard to get their levels up. So in that study, no one's levels went above 80, and it's about at 150 where you worry about effects of hypervitamin D.
Mike, so they're also actually looking at other ways of getting vitamin D as opposed to through the gut, because they don't absorb it very well. So topically, other forms of putting it under study, that way we can try to get these levels up. Because supplements, and even if they take it, it often do get insufficient.
Yeah.
Yes, getting at the pancreas problem, has there been any studies on the CF pancreatic sufficient patients?
The other studies, so in our study, we took out the sufficient patients just so it was less of a confounder. The other studies include both but don't separate them out. But no one's looked just specifically at the sufficient group in their incidence of vitamin D deficiency.
And the other thing is, you didn't mention vitamin D levels in your retrospective study.
So on average, they were all within the normal range and no difference among the groups. And same with vitamin A, which that was, what we notice in clinic too, is vitamin A and E with the just the CF vitamins that they're given and their enzymes, they seem to absorb, and usually we don't have a problem with those, but vitamin D, they always tend to be deficient, even with high doses of supplement.
Do you have any thoughts about that, Harvey, as to why they are so low? Getting that vitamin D up, and maybe it's a liver dysfunction?
And part it could be some liver dysfunction. The other thing is getting at the issue of, in regards to the lungs, is whether the elastase levels might be low also.
Yeah.
Vitamin D deficiency as well as the other proteins.
Right. So those we don't routinely measure, but you're thinking that the vitamin D might also adversely affect cholesterol,
Contribute to many of the problems that were brought up.
Did anyone look at that in the animals?
No.
The issue of causality, whether the vitamin D levels are low because patients are in the hospital all the time, or vice versa. Is there a control population we could look at for somebody that was hospitalized for non-pulmonary reasons in the past? Is it just being in the hospital a lot leads to low vitamin D levels? I'm trying to think what population would be asthmatics or bronchitis.
Right, and then it seems like vitamin D's been kind of suggested to play a role in so many different diseases that you'd wonder if their vitamin D levels are going to be low for other reasons for hospitalization too, like cancer. And
Yeah, kids who are institutionalized for whatever,
yeah, like getting at the sunlight exposure, you mean? Yeah, that's a good thought.
Some of the other things that may contribute to the difficulty is the role of the intestine, whether it doesn't function as well, or whether it's actually a little shorter. And also, because of all the antibiotics, whether we don't have enough protein, contribute.
Right.
Going less with oral antibiotics probably wouldn't be passing more than inhale, but you're right, because there is effect of swellings. much.
Thank you. Thanks.
Did we talk in the paper at all about cytokine levels and things like that, or is anything?
No.
Just because I know there's one mouse study out there with influenza where they exposed the mice to influenza and they've either treated them with vitamin D or not. And they actually found that it wasn't so much the influenza titer in the lungs, but the inflammatory process. The idea being that people get less severely ill with influenza when they have been treated with vitamin D, or the mice do, because of the decrease in that overreactive response to the infection. I was just thinking about that, listening to in terms of the hospitalization part too, the exacerbation.
Right.
So the same stimulus is there, but they don't tear up the lungs as much with the they have more down regulation of that inflammation. Yeah, I think that's a very plausible hypothesis.
Right.
Something that could be incorporated in ever do a clinical trial to be incorporated some sort of measure of inflammation at the time between groups that are hospitalized or not.
Can you measure that from a bronch? Like look at.
Well, you could probably, yes, you definitely can. It has been. It has been done. And there's a collection of those at Denver, and actually there might be some specimens actually that will be available, frozen.
Interesting to look at. You did a really nice job.
Thanks. You too. Good luck with everything, Linda. You'll have to send me pictures.
On our way.
Okay.
Hi, how are you?
Hi.
Seen you in a long time.
Wheels working out.
It did.
That's
It all
okay.
worked out well.
I have one question. How far back did you go in the retrospective study? What year?
2000.
2000.
Yeah.
Was that? Did you just say that
Huh?
in your talk? Did
Yeah.
You say, okay. I missed
Yeah.
that. Okay. I was just thinking. 2000. Okay.
As far as what they were getting for supplements, is that what you're thinking?
Yeah. Okay. Thanks.
Yeah.
Can give you a hug goodbye.
Yeah. It's good to see you.
Just so happy for you.
Thanks.
Congratulations.
Thanks. Yep, it's good. Yeah, we're having a good time. Settled in. The girls are in 1,000 different things. And it's been good.
Can I give you an answer?
Yeah. So.
And we had no witness. You'll be very happy.
Where'd you guys go?
She wanted to go to Bona. They said they didn't care, so went to Bona.
Yeah, that's Terry's favorite place.
Yeah. There's those little salad thingy-majiggies,
Yeah.
whatever they're called, bun, whatever.
Yeah.
In it like this that you can't pronounce.
Right.
I haven't mastered that yet. Some things I can get away with that. I can't.
Yeah. Thingamajiggies works well for me.
That works.
All right. You too. No, I think they don't have it this week, but I'm going to head back. So,
Okay.
yeah, where are you guys? Do you have anyone new?
Well, not since I've been